talk about the Anderson medical model, when I talk about the Anderson medical model, what I'm referring to is 2 articles that were published in and around 1993. So essentially, Maxwell Anderson actually published 2 separate articles on managing dental caries. And in those articles, he used evidence-based dentistry at that time to support specific recommendations to help minimize and prevent the future occurrence of dental caries. So again, if you think back to the surgical model, where we're just technicians, we're drilling and filling, we're not really thinking about why things occurred and how we can actually prevent those things from occurring in the future, that's a totally different mindset. The Anderson medical model actually is a different approach. It actually is very concerned about what caused the issue and how do we prevent it from occurring again in the future. So with the medical model, diagnosis is huge. You really need to use some type of risk assessment form to correctly identify those risk factors. Now, one of the biggest goals of the medical model is to minimize disease and prevent disease from occurring again. And when you manage your disease process using the medical model, you're actually going to be kind of directing yourself towards a goal, an attainable goal that you can set for your patient. And we'll go through the steps of the medical model so you better understand what we're talking about. But essentially, you have to have a goal in mind, and you have to have a way to reassess that patient periodically to make sure that they're maintaining those goals. So one of the things the medical model did was it actually identified that, okay, this is not just a bunch of plaque that's causing an issue, it's specific plaque that's causing the issue. Cariogenic biofilm, right? What we talked about earlier. So specifically in the medical model, they target Strep mutans as the primary bacteria that we analyze and that we periodically check to see what the levels are of that specific bacteria. So one of the things that the medical model actually advocates is testing the patient's Strep mutans levels. Now, I can tell you from my experience, I typically do not do this on a regular basis. However, I do see a huge benefit to doing this. It definitely offers you objective information and objective feedback on whether or not your treatment is working. So when would you actually test the patient's Strep mutans levels? Well, I can tell you, if you're treating a high caries risk patient, you can guarantee that that patient's going to have Strep mutans levels greater than 100,000 colony forming units. It's just going to be a given. So doing a test up front is almost a waste of time because it's going to be high. What I would recommend, and what typically the medical model would recommend, is that you do your initial therapy to manage that disease process, which will include an antimicrobial directed treatment. And once you've done that antimicrobial treatment to help lower those Strep mutans counts, then and only then at that point would you actually test for Strep mutans to determine what the level is for your patient. If the level is still very high, that would indicate that you need to continue treatment longer. If, however, the level has reduced substantially, then that means that you may not need to continue your current therapy. You could potentially shorten that and then retest at a later date. So the 2 big goals of the Anderson medical model is to do timely restorations, meaning that we try to remove any caries and properly fill the tooth as quickly as possible. And then the next big goal of the medical model is to eliminate that disease process from occurring again. So 3 things that I would recommend that you do prior to initiating the medical model is to, 1, do a caries risk assessment. It could be the ADA's, the CDA's, or your own, but you need to identify which risk factors are really pronounced and an issue for your patient. The second thing you need to do is a dietary analysis. I would identify what the patient's normal diet is like and then determine if there's any modifications that need to be made based on your dietary analysis. And then the third thing is, if you suspect the patient has salivary related issues, you may want to do some salivary testing to determine if saliva flow or quality of that saliva is a potential contributing factor for your patient having dental caries. All right, so we're going to look at the 7 steps of the Anderson Medical Model. We're going to go through each one and we're going to talk about those individually. So step 1 of the medical model is to treat your teeth that need restorations. Sometimes we'll call this caries control restorations. Essentially, any tooth that has a frank cavitation, it's going to get a filling. Now, this could be a temporary filling or you could place a permanent filling. The choice is really up to you. In certain situations, if the patient has a lot of cavities that need to be treated, and let's say the conditions in the mouth are less than ideal. They have gingivitis, you barely touch the gingiva, they're bleeding everywhere. Sometimes, especially in the anterior, that's not an ideal condition to place a composite. So sometimes, using the medical model, it may make more sense to place a temporary restoration, get the patient cleaned up, get their mouth a little bit healthier, and then when the conditions of the environment have improved, go back in and place a definitive restoration at a later date. Now, on the other hand, it does make a lot of sense to just go ahead and place the definitive restoration if you can. Why do something in 2 steps if you can do it in 1? You're going to have to decide this on a case-by-case, scenario. Determine if it makes sense to do the treatment in 2 steps or if it makes sense to do it in 1 step. The other thing you're going to do as part of your caries control is any teeth that are non-restorable that cannot be fixed, they need to be extracted. That's also part of this treatment, is to remove any teeth that are non-restorable or cannot be fixed, in addition to your caries control restorations. The next thing you're going to do as step 2 of the Anderson Medical Model is you're actually going to apply sealants to any of the teeth that need them. So any premolars or molars that have deep pits and fissures that do not need restorations should be sealed with a sealant using this medical model approach. Essentially what you're doing is you're preventing future caries in these areas. So it's more of a preventive treatment than anything, but it's certainly something that should be considered in your high caries risk patients. Now, sealants have had a very long track record. They have very high success when they're placed in the right conditions, when they're placed with good isolation, and you're using resin-based sealants. And a lot of these actually have fluoride releasing components as well, so that can be beneficial for strengthening the surrounding tooth structure. So definitely consider using sealants. In young children especially, there's a lot of literature that supports the use of sealants in children and adolescents. Now, if you look at the literature for adults, it's a little bit lacking. Essentially, it's more expert opinion, because what they've done is they said, okay, we have an abundance of literature for children that suggests that sealants are very good and they're very beneficial. And what they did was they kind of extrapolated that information and applied it to adults. And so you're not going to find a lot of literature to support this that's based in good science, that's like randomized clinical trials or systematic reviews for adults. But expert opinion dictates that you should use it because we know it works in kids. Why wouldn't it work in adults? Now, some people place sealants with bonding agents. Some people just etch the tooth and then place the sealant. Either way, the choice is up to you. There's literature to support both. Some articles will say that there's really no difference if you place a bonding agent after you etch the tooth versus if you do place a bonding agent. Choice is yours. The big thing is identifying those patients that need sealants and placing that as a preventive measure to prevent further dental caries on those teeth. The third step of the Anderson Medical Model is to use chlorhexidine or some type of antimicrobial mouth rinse. Now, the idea here is that we're trying to target that Strep mutans and actually lower the level of that bacteria in the mouth. Now, why do we do it after you've done the caries control restorations? Well, the idea of this is simple. If you place a patient on chlorhexidine mouth rinse early on, before you've done any of the fillings, in the Anderson article, he actually talks about the concern that you could be creating what's called a superinfection, or basically not targeting the bacteria appropriately. See, if you have a patient that's got a large cavity, there's a lot of bacteria on the surface of the tooth, but there's just as much bacteria inside the tooth. When you use chlorhexidine, on a patient that has a lot of cavities, you're eliminating a lot of the bacteria on the surface, but you're not really reducing the bacterial counts within the tooth. So what the Anderson Medical Model actually recommends is you do the fillings first and you remove all those hiding places, right? You do the fillings, you do the sealants, and now you've taken away all the little places where bacteria can hide. And then you place the patient on the mouth rinse. They start using this and it basically kind of just drops an antimicrobial nuclear bomb in the mouth and just reduces all those bacterial counts. That would have been a lot harder to reduce if you placed the patient on that mouth rinse when they had cavities. So the typical approach is to use a chlorhexidine mouth rinse, a half an ounce like twice a day, rinsing for 30 seconds to a minute, and have the patient actually use this for up to 2 weeks after you've done your caries control restorations and your sealants. It really doesn't matter if the patient brushes first or after. I typically have the patient brush their teeth first and then do the chlorhexidine rinse after the fact. Because again, we're moving a lot of that plaque from the teeth and then we're kind of dropping that antimicrobial nuke in the mouth to help lower those bacterial counts. The other part of this step is to actually use a fluoride varnish on your patient. So in the specific medical model that is discussed here, they actually recommended using a fluoride varnish up to 3 times in 1 week, and then using it biannually or at least annually after that. I would use fluoride varnish at least once every 3 months or once every 6 months if you can on those high caries risk patients, especially so in patients that perhaps had glass ionomers or resin modified glass ionomers placed as part of their caries control restorations. These type of restorations can actually be recharged with that fluoride in the varnish. A couple more things about chlorhexidine. When a patient uses chlorhexidine for up to 2 weeks, it actually has what's called substantivity, meaning that even after it's used, it still continues to work. It still continues to be beneficial for that patient. Now, there are studies out there that show that once the chlorhexidine is used, it can actually continue to suppress the Strep Mutants counts greater than 12 weeks, and in some studies up to 26 weeks after it was initially used. So you put the patient on this for 2 weeks, you don't have to have the patient use this again unless you determine at a later date that they need chlorhexidine again to help lower those Strep Mutants counts. So chlorhexidine has good substantivity. It actually can cause cell lysis because it alters the bacteria's membrane. It prevents the bacteria from adhering to the tooth, and it also helps reduce plaque formation on the tooth. Now keep in mind, there are some side effects that are associated with chlorhexidine use. Some of the big ones are the patient can have an altered taste if they use it for too long. They can actually have staining of their teeth if they use it for too long. And they can have a buildup of tartar or like just calculus buildup on their teeth if they're using that for in excess of sometimes 2 to 4 weeks. Now, if you look at the ADA's website and you look specifically at mouth rinses, chlorhexidine is not recommended based off of good, sound, evidence-based dentistry. It's really empirical. It's one of those recommendations where we know what it does, it reduces bacteria, and we know we're kind of fighting bacteria when it comes to dental caries. So we just kind of imply its use for that specific situation. All right, step 4 of the Anderson Medical Model is using a xylitol-based gum. So xylitol is a 5-carbon sugar that essentially Strep Mutants cannot feed on. It can't metabolize it. So therefore, if you're using this, it actually does not allow the bacteria to produce lactic acid as a byproduct. Just the act of chewing gum in and of itself is going to help produce a lot of saliva. So as we discussed earlier, saliva flow is going to be very important. It's going to help, clear the bacteria from the mouth. It's going to help bring all those good minerals back into the mouth for remineralization. And, in general, just chewing gum, moving that around the mouth, it's also mechanically debriding the teeth as well. So the general recommendation is to chew 2 pieces of xylitol gum up to 3 times a day for at least 5 minutes at each exposure. Essentially what that comes out to is it's about 6 to 10 grams of xylitol per day. That's usually the therapeutic range for using a xylitol-based gum. So apparently xylitol is actually toxic to dogs, so you don't want to leave this out where your dog could potentially get into it. And it can also cause mild diarrhea if it's used in excess. So you don't want to really use more than that recommended dosage per day. Now in the handout I actually have a bunch of different types of gums listed. I personally think that if I'm going to recommend something to my patient, I should at least kind of show them where they can get it or what some options that's available to them. So that's what you'll see in the handout. You'll see a lot of different brands here. It actually shows you what the xylitol content is in those specific types of gum. And typically the general rule is if you're going to use a xylitol based gum, the best ones should have xylitol as the main ingredient. And so, just show them these different types of gums that's available. That way when they go to the store or they go to the supermarket, they can actually look for these specific types of gum, maybe even put it on a handout for them that they can take home with them. And then one of the easiest ways too is they can even go online. Just go to any website, Amazon, search these specific types of gum and actually order the product online. You can many times buy this stuff in bulk. So they could have a huge supply of this. You can keep a little bit at work, in their car, wherever. And if they're chewing this frequently throughout the day, that's going to help them reduce that caries risk. So step 5 of the Anderson medical model is to use an over-the-counter fluoride rinse. The patient's already been exposed to the fluoride varnish, but now this is something they can do on a regular basis, daily, up to 2 times daily. They can expose themselves to an over-the-counter fluoride rinse. Typically this would be recommended to start after the chlorhexidine rinse, but essentially, they're exposing themselves to more fluoride. They're brushing their teeth, they're flossing, and then they're rinsing with a fluoride rinse, and they're helping encourage that remineralization process and to introduce more minerals into the tooth and to strengthen the tooth from the fluoride exposure. Now, I typically will tell patients to brush, floss, use the fluoride rinse, rinse for at least a minute, and then spit that out, and then don't eat or drink anything for at least 30 minutes after they brush their teeth. Same goes for the chlorhexidine. If they're using chlorhexidine rinse, I have them not eat or drink anything for at least 30 minutes after they do that. They need adequate time for exposure to that product. That way that they get the most benefit from that. If they're going straight from brushing their teeth to rinsing or to actually eating, now they're going to be just washing away a lot of that good product they put on their teeth. So I don't even have them rinse their mouth out afterwards. I would just recommend, prevent the little toothpaste ring, wet your hand, kind of wipe your face off a little bit, but leave all that stuff you had in your mouth there, right? Just spit out the excess, but leave all the rest there. That way they get the max benefit of that fluoride in the toothpaste and in the mouth rinse. All right, so step 6 of the Anderson medical model is to have a good recall program and a way to test the bacteria. So depending on what your caries risk is, you may want to see that patient every 3 months initially, or every 6 months initially, or maybe even annually, right? So determine your risk factors and then determine how often you think you need to see the patient to prevent things or at least catch things before they get too advanced. If it's a high caries risk patient, I personally like to see those patients every 3 months until I feel like they have a pretty good handle on the disease process and we're doing a good job managing it. Then I would push them out to every 6 months. And then if they're doing really good at every 6 months, maybe we could go out to every year. But I start more frequent and then I kind of work my way up to something that's a little less frequent. Now again, this may be a good time to do the bacterial testing so you can actually retest the Strep Mutants levels and see if they're at a lower count. If they're still at 100,000 colony forming units and above, then you may need to put the patient back on chlorhexidine, continue your fluoride varnish, continue all these other things that you've been doing to kind of help manage that disease process. If, however, their colony forming units are actually very low, then you know you don't need to use the chlorhexidine anymore. Maybe you can just do some fluoride rinse over the counter, and see the patient every 3 months, every 6 months, and then kind of follow up as needed. Now there's at least 2 types of bacterial tests that I know of. I do have a slide of those in the handout. One is saliva check mutans, and the other one is the CRT bacteria. You know, I personally think these are a little expensive for how many test kits you get. So I wouldn't necessarily do this on every single patient, but on those patients that are just rampant caries, they have very high caries risk, I could see pulling this out and using it, and especially in the ones where you're really trying to change their mindset. You're really trying to change the way they've been doing things in the past. You know, having something objective like this that helps measure bacteria in the mouth and gives them some feedback could be very motivating for that patient to kind of continue those oral hygiene regimens, those dietary modifications, etc., for the success of their caries control long term. All right, step 7 of the Anderson Medical Model is definitive restorations. Only if you did not do definitive restorations in the beginning. You know, like I said earlier, when you do caries control, you have the choice of doing temporary or definitive restorations. The classic model was to do temporary restorations up front and then to replace those later with definitive restorations. But if you did do temporaries up front, now's the time to actually replace those with definitive restorations. And the big thing that you need to keep in mind when you're doing the Anderson Medical Model is the recall. You know, every patient should have, in my mind, a restorative recall and a perio recall. How often do they need to be seen to have their teeth cleaned? How often do they need to be seen to check for dental caries? If they're high caries risk, I would recommend, again, you start them at 3 months and then you kind of work them up to 6 and then maybe to a year. But you need to think about what you're going to do with those visits. Do you need to reapply fluoride varnish? Do you need to retest the Strep Mutants counts? Do you need to reinforce oral hygiene procedures or techniques? You know, do you need to think about just, going over like what's your daily regimen, right? Are you using the fluoride rinse we talked about? Do I need to put you back on chlorhexidine? Those are the kind of things that you need to make sure you're touching on at these recall visits, so the patient's constantly having continuity there. They're not just getting treated and then they're just kind of dumped off to just defend for themselves. The recall is very important because you need to intervene as early as possible if you need to prevent that caries process from continuing to get worse. You know, and the other thing too is, like, if you're seeing the patient every 3 months or every 6 months, you're able to see if restorations are failing a lot quicker, so you can intervene and replace those if necessary, or if you need to repair those. But you can also identify if a new carious lesion is present and then catch that before it gets out of control, before it's a lot bigger. So really reinforce the necessity and the importance of the patients having adequate recall. All right, so that wraps up the caries lecture. We talked about a lot of different things. We went over a lot of things pertaining to diagnosing different types of caries, you know, just how you can use risk assessments to your benefit, how you can manage the caries process using the medical model. You know, there's a lot of things we can talk about that we didn't. And, you know, I would encourage you to, go back through the handout. If you have any questions, let me know. If you have other things that you've done that you think are beneficial, please post that in the comments. Please let everybody in this comprehensive dentistry community just know about like what things you're doing. And two, if you're doing specific things, I always encourage you to try to back that up with the literature, to try to have something that is evidence-based that supports why you're doing what you're doing. So please share your ideas, share your comments and your thoughts about this lecture with the community. And I'm very interested in hearing from you and seeing what kind of things that you're doing on a regular basis.